So my name is Vincent Thijs. I'm a neurologist from Leuven in Belgium.
Who is at risk for AF?
AF is a disease that strikes mostly the elderly with increasing frequency above 50, but rising up to 25% of the people above 80. So it's a very common disease. Once you're getting older, everybody is at risk of having AF.
We started to talk about this a little bit, but the lifetime risk for AF stroke.
The lifetime risk of stroke is quite similar to the lifetime risk of AF actually. If you have AF, you're really at risk if you're not treated. If you're treated and you're identified, then we can prevent the stroke. When people have had a stroke, they are typically monitored in the stroke unit for, say, 48 to 72 hours. And after that, they will receive a Holter monitoring device typically to identify AF, but we know that that often is not even sufficient, and that's the reason why there's new technology that's being developed, and that's quite exciting.
Can you tell us about the Leuven database?
For the purpose of this presentation, I looked into our AF patients, the subgroup of patients that had a stroke and had AF, and looked at their age. And what was kind of striking is that, as expected, actually, the older you were when you've had your stroke, the higher the risk was to identify atrial fibrillation, going up to 40 and 50% of the patients that had a stroke when they were more than 80 years old. Stroke is like cancer, it's very heterogeneous. Also what we found was that if you have had a stroke and it's related to AF, your stroke is probably more severe. The impairment you have from your stroke is more worse, so more frequent. The only problem is that we don't have good means to identify AF when it's at the earliest stages of the disease.
What are the most important aspects clinicians should be aware of regarding strokes?
I think the most important is that any type of stroke can be caused by AF, meaning that you cannot tell from what the patient looks like whether it's related to AF or not. So you have to think about AF all the time with every stroke patient you see, especially as patients get older. So for that reason, if you have a stroke, think AF might be the cause, but if the patient presents early enough, give thrombolytic therapy, and AF should not be a reason to withhold that.
And are there certain types of strokes that are associated with AF?
Well, there's only one stroke subtype that is not associated, and that's lacunar stroke, but we know that you need to be aware that even in that subset you can find AF in a smaller percentage of the patients. So even there you have to be open-minded and think about AF and use the means to detect it.
And you mentioned that the prognosis is sort of worse for AF-related stroke. Why is that?
The tendency is that when you have atrial fibrillation, you develop a clot in your heart, and this travels to the brain through the vasculature, and it happens suddenly. It blocks off an artery. Whereas in many patients that have other types of stroke, this is more a progressive disease, a progressive buildup of narrowing of the vessels leading to the brain, and there the brain has time to respond actually by making little bypasses that we call collaterals themselves. The clots that are formed due to atrial fibrillation, they might resorb spontaneously, but when they do, there is a sudden restoration of the blood flow to the brain, and this might lead to actual seepage of blood products within the brain tissue. This is what we call hemorrhagic transformation, and it's more frequently seen with cardiac emboli. Probably because the characteristics of the clot are a little bit different than what we see from clots that arise due to atherosclerosis of the neck vessels. So these are some pathophysiological reasons. It's more in terms of hypothesis than that we have actual good data to support those findings.